any of the seminars before, these new seminars?
I believe we've avoided for the past 8 years.
To dodge it.
Yeah.
Okay, I think we're going to get started. Good afternoon. Those who are online and those in person, welcome to today's School of Public Health noon seminar. And today we're going to have a presentation from Edina. And Edina is a research officer and EIDM specialist at the Vaccines for Africa Initiative. And for those of you who knows VACFA, we deal a lot on issues around vaccines and immunization. And today's topic that Edina is going to talk to us about is on the hepatitis B birth dose, vaccination in Africa, no-brainer or a complex public health intervention. Just a little bit of introduction of Edina. Edina has a PhD in virology. And subsequently, I think Edina saw the very useful need to space of public health. And after that, she did an MPH at UCT, while still undertaking postdoc fellowship at VACFA. And that was 5-6 years ago.
The postdoc?
Yeah.
2 years ago.
But that's when you finished. But I think
5
when
years,
you started,
5 years.
yeah. So I think that you've been with VACFA since 2018. And it's been wonderful to be.
For the most part.
For the most part. So Edina, over to you and tell us more about the topic. Thank you.
Thank you very much, Ben, for that kind introduction, and good afternoon to everyone. So I hope that the online team can see us. We're having to use my laptop, so you'll probably just be seeing my mid section, which isn't great. So I'm quite excited to talk about this topic. It feels like it's quite timely because we've just commemorated 50 years of the expanded or the essential program on immunization. And data coming out has shown that immunization has had a significant impact, saving 154 million lives in the last 50 years. And that equates to 6 lives saved every minute of every day for the past 5 decades, which I think is just a remarkable achievement. But unfortunately, there are still several gaps, and there are still some challenges in getting vaccines to those who need them the most. And one of those vaccination programs that we are struggling with is the hepatitis B birth dose, which I'm hoping we can discuss a bit today. And I'm hoping to address this question on whether it's a no-brainer or a complex public health intervention. So also important for me to mention that what I'll be sharing with you is coming from a much larger study with funding support from the Gilead Sciences Research Scholars Program. And in this much larger study, what we're looking to do is to characterize the neglected burden of viral hepatitis among HIV-exposed, uninfected, and infected pediatric populations. And in this study, we have 3 main components. And what I'll be sharing today comes from our most recently completed qualitative systematic review, which was led by Tasneem, who recently graduated as well. She's currently at work, but is probably joining in if she finds a minute. And in this qualitative systematic review, we aimed to explore the influence of health systems complexity on the performance of hepatitis B birth dose vaccination programs in Africa. And then I'll be supplementing this with some preliminary findings from our lab-based country case study, where we're looking to determine the seroprevalence and risk factors of viral hepatitis among children who have been exposed versus unexposed to maternal HIV infection. I'll be drawing on some of our publications from this very recent study, and also useful to mention that Tasneem and I will be sharing components of this work at next week's African Viral Hepatitis Convention, which is happening at the CTICC. All right, so if you've been following some hepatitis literature, you may have come across the WHO's recent report on the state of viral hepatitis globally. And in fact, some really concerning reports, outcomes, showing that we are losing 3,500 people to viral hepatitis every single day, which is a huge public health concern. And the reason why it's even more frustrating is that we have all the tools at hand. We have very effective vaccines against hepatitis B. We have improved diagnostic tools and treatments, cures for hepatitis C. And these products, the prices of these products are decreasing, by the day. And so there's no reason why we should be in the situation that we say, where we're losing 1.3 million people every year to viral hepatitis. And in fact, viral hepatitis has now become the second leading infectious cause of death globally, equaling TB as a top infectious killer. It's important also for me to mention that of the 1.3 million deaths that we're seeing every year, 83% of those are associated with hepatitis B, which is of course caused by the hepatitis B virus. And so that's the major public health concern when it comes to viral hepatitis. And of the deaths that we're seeing globally, 43% of these are happening in the Western Pacific, and 25% of these are happening in the African region. So these are the main contributors to the problem that we're facing when it comes to viral hepatitis. And so obviously there's a need to intensify our strategies to ensure that everyone everywhere, especially in low and middle income countries, have access to all the most effective tools against viral hepatitis. There is some good news. The report shows that there's a decline in new infections. Which means that in 2019, we're recording 2.5 million new viral hepatitis infections, and now we are at 2.2 million. And of the 2.2 million, 1.2 of these are caused by the hepatitis B virus. So showing that it's still a major concern. And the African region accounts for 63% of these new infections. So that is the problem area. And I don't think it comes as a surprise to any of us, but we'll talk about that a bit more later. So the decline actually suggests that globally, our preventative strategies are in fact working. They've been effective at reducing the incidence of infections globally. And these strategies include the hepatitis B vaccine. And we administer the vaccine at two main stages of life, I would say, primarily at birth and also during infancy in a three-dose schedule. And this is a critical time because it's the best time to prevent infection, because infections attained in early childhood have a 90% chance of progressing into chronic infection, and chronic infection is associated with liver cancer, fulminant hepatitis, as well as death. So essentially, we need to strengthen and expand access to these strategies because it's crucial to sustaining impact. The declines we're seeing are good, but they're not great. And so we need to see more of that by expanding access. So what are the progress and gaps in preventing new hepatitis B virus infections? Well, I mentioned we provide the hepatitis B vaccine at birth as well as during infancy. So the vaccine that is administered at birth is given at 6, 10, and 14 weeks generally in most countries. And in fact, for that particular hepatitis B vaccination program, we have global adoption. In terms of coverage, the coverage of the hepatitis B dose the doses that are given in childhood, we have coverage of about 84% globally. But of course, there's variations when you look at the different regions in the world. And it's obvious from the graph that comparably, the African region isn't performing as great as all the other regions, with coverage sitting at 72% currently. And then when it comes to the birth dose, fewer countries have introduced the hepatitis B birth dose. And important for me to mention now that the decision to introduce the vaccine is based on if you have a high risk of mother-to-child transmission of hepatitis B in your country. So most of those countries in the American region, in the Americas and Europe, might not have a hepatitis B birth dose because the risk is in fact quite low, the risk of mother-to-child transmission. So 113 countries worldwide have introduced the hepatitis B birth dose with coverage at 45%. And in the African region, only a third of countries have introduced the vaccine with coverage at a dismal 18%. And that is a real concern because the problem actually sits with our region. So you will note that where we have the pale blue all around the world, the prevalence of hepatitis B among children under 5 is actually less than 1%. But in the African region, it's at 2.5%, and it can go as high as 13% in Sudan. And so this is really where we need to see a focused public health approach. So just to mention that with that graph that I just showed, it means that the African region is on course to be the region with the highest burden of chronic hepatitis B without intensive action. And so in a recent scoping review that we published, we highlighted how we're seeing weak adoption of the hepatitis B birth dose, which is a highly effective tool. And we are in the countries that have actually introduced the hepatitis B birth dose, the coverage is very poor. The performance is actually quite poor. So there's an urgent need to expand access in order to prevent future generation of new infections, cancers, as well as deaths. And we have several interventions to prevent mother-to-child transmission of the hepatitis B virus. It starts off with screening pregnant women and linking them to treatment and care. But unfortunately, the rates of screening within our region is just dismal. We have the universal hepatitis B infant vaccination, which is doing quite well. We're reaching a lot of infants with the vaccine, but we need to supplement that with the hepatitis B birth dose, and that's where the link is missing. And so there are several missed opportunities to control HPV and TCT, mother-to-child transmission in the African region. And I had the great fortune of being at the World Hepatitis Summit in early April. And, everybody was up in arms because we couldn't understand why we have an effective tool that could contribute to 90% to 100% protection for children, and yet it wasn't available to them. And what made it worse is we realized that the money isn't the problem. Low-income countries can access the hepatitis B birth dose at 40 cents per dose, and middle-income countries can access it anywhere between 50 cents and 75 cents. So it doesn't seem like that's the problem. And so many of those in the room were saying, let's just go ahead and get the vaccines to these babies. Sorry about that. Let's just go ahead and get it to them. But it's not as simple as that. We understand that there are some systemic issues within our setting. There has to be a reason why we're seeing 18% vaccine coverage in those countries that have introduced the birth dose. And that is what I'm hoping to talk to you about now. So with that understanding, we conducted this qualitative systematic review, trying to draw from country experiences with the hepatitis B birth dose to provide complex explanations of why simply introducing the vaccine will not contribute to the high coverage that we in fact need. And we approached this with a complex system lens. And the reason why we went for this is we didn't want to be the guys on this side where we just draw up a laundry list of all the factors of why something is not working. We wanted to come up with complex explanations of the factors that are contributing to the low vaccine uptake and utilization, in the hopes that we can also inform complex solutions within our region. So in our systematic review, we found 8 key themes that suggest the sources of complexity when it comes to existing hepatitis B birth dose vaccines within the birth dose vaccination programs within the African region. And I'll try to give an overview of each of these 8, but then in the next couple of slides, I'll show how these factors dynamically interact to contribute to the low vaccine uptake use within the African region. So when it comes to the availability and interpretation of national policies, I mentioned that there's a birth dose, but the birth dose has to be given at best, ideally at 24 hours after birth. It's the ideal time to prevent mother-to-child transmission. Next best time is within 7 days after birth, and then worst case scenario, 2 weeks post-birth. But then the longer you wait, the wider the window gets in terms of the possibility of the child developing a hepatitis B infection. But the challenge we've seen in many of our African countries that have the vaccination program in place is that healthcare workers tended to wait until the 2 weeks because they assumed that that might be the best time. It was convenient for them as healthcare workers to vaccinate at that time rather than following the guidelines, and I'll come back to that. And then in terms of vaccine supply, there've been reports of stockouts. These are rare, but when they do happen, it means that you missed that 24-hour window or even your 7-day window, and so there are some missed opportunities there. In terms of finance, in many of the countries, the vaccine is available free of charge. In countries where parents had to pay for the birth dose, of course, they didn't feel the need to participate in the vaccination program. In those countries where the vaccine is available free of charge, some in fact have informal charges. And so some parents have to pay for gloves and cotton buds and all of that, which just discourages them from actually getting the vaccine. So the informal charges are also a particular concern. Then there's the capability of the health workforce. This is not our first birth dose. We have the oral polio vaccine as well as the BCG for TB that we administer ideally at birth. Those tend to be a little bit more flexible compared to the hepatitis B birth dose because you want to vaccinate the child before they go out into the community and be exposed to TB or to polio in the environment. So your best time is just before the mother goes, but some mothers come back later. And so we saw that some healthcare workers chose to either wait to give all 3 vaccines at the same time, which delays the hepatitis B birth dose, increases risk of infection. And for whatever reason, they were more comfortable administering OPV, oral polio, and BCG, but not the hepatitis B birth dose. And it's quite unclear why there's that lack, but it probably has something to do with the lack of training. And then in terms of monitoring systems and impaired feedback loops, it comes down to how we record and monitor the vaccination program. So in some cases, there's a heavy reliance on paper-based, home-based vaccination records. Sometimes the facility records don't have a slot to write in when you administered the hepatitis B birth dose. And we're seeing in some countries that healthcare workers are recording the birth dose all the way at 6 months, which of course kind of defeats the purpose, right? And then system design also key. If a mother gives birth on a public holiday or over a weekend, she's out of luck because there's no vaccination program. You'll have to wait until the vaccination slots during the week. And those are, again, contribute to missed opportunities. In terms of maternal education, what came out strongly was that having a secondary education or higher, or at least any kind of education at all, just made the women seem to take up the advice, the recommendation of the healthcare workers a bit more, and they adhered to the timing and they accepted the hepatitis B vaccine. And so maternal education was an important contributor. And then in terms of wider contextual factors, here we're talking about cultural and religious practices or just observances. And these were key because the African region has a substantial proportion of home births. When the births happen at home, the vaccines are in the facility. And so there's that mismatch in terms of linking parents to appropriate care. So let's unpack this a little bit more. Why is timing so key when it comes to the hepatitis B vaccine? It's because when you give the sooner you give the vaccine is the sooner you prevent mother-to-child transmission. And so the recommendation is that 24 hours of after birth is the best time to prevent transmission of the virus from the mother to the child. But there are variations, as I mentioned, in terms of how countries have adapted this recommendation in their own countries. And there's an experience from Nigeria where nurses tended to wait until 2 weeks, or they weren't comfortable vaccinating a newborn, and so they wait until they weigh the child, and whatever number comes up that makes them comfortable, they go with that. And so we see a lot of delays. The coverage might be good, but it might not be doing its job because the timing is off. And when in Nigeria, when the government decided, okay, no, we need to clamp down on this and just stress a bit more about the 24-hour timeline, what it did was it made the healthcare workers think that you either give it at 24 hours or not at all. Again, misinterpretation. So obviously there's a need for clear policies and guidelines as well as training for the delivery agents just to ensure that we have higher uptake. Also, an important thing that came up was ANC attendance. And so it's a real contributor. You know, the more pregnant women attend their visits, the higher the likelihood that they're going to get in touch with education and information about vaccines, including the hepatitis B vaccine, and the more the likelihood that they're going to adhere to the timing once they give birth. And so overall vaccine coverage rates were shown to be high in instances of high ANC attendance. And in Nigeria, women with a history of ANC attendance were 10 times more likely to present on time for the hepatitis B dose. And so key in terms of defining our strategies when we're trying to scale up hepatitis B dose in Africa. The role of cultural and religious contextual factors came out quite a bit. It seemed key. And there were important cultural and religious observances that have relevance to whether or not our hepatitis B dose vaccination programs are going to function optimally. And some of these are in some cultural sectors, women are not permitted to leave the house until their children are named, and that can take 7 days, or until their male children are circumcised, and again, that could take anywhere from 7 days. Also, for some communities, paternal consent was critical, and so if the father was not around or he didn't consent to vaccination, there's a likelihood that the child would not receive the vaccine at birth. Also, religion played a huge role in terms of home births, and that was also crucial, and I think I've already touched on that. So within the African region, home births are anywhere, in the region of 40% and higher. And this often means that we are not able to reach these women once they give birth, because the vaccines are typically offered in the health facility. And so there's limited vaccine resources and services for children that are born outside of health facilities. So if you had to compare children born in facility and out of facility, in Nigeria, they saw that the hepatitis B dose coverage was greater than 75% among children who were born in facility, and 33% for children who were born at home or anywhere else. So there's a clear demand for us to better design our health systems and our health services to either encourage, facility births, but also not to dismantle existing birthing and cultural practices to accommodate them. And I'll touch on how we can go about that. So we found that if you leverage the role of traditional birth attendants, you are more likely to increase acceptance and trust and use of the hepatitis B dose, because these cadres serve as a conduit between the health system and the communities. So for traditional birth attendants, they could either serve as those that advise pregnant women to make sure that they come in for the birth dose once they give birth, or to link services to them through outreach services. In some communities, it might not be birth attendants, it might be doulas, or, they're very fancy names for who journeys you through your birthing practices. And so those are the kind of individuals or the kind of stakeholders that we could engage and leverage to strengthen hepatitis B dose vaccination programs within our setting. So how the services are designed matters. In Gambia, we found that although they had scheduled days for the vaccination, they also incorporated supplementary services where they will go out into the communities and deliver the vaccine. So bringing the services closer to the communities really helped. The same for Senegal, where if they had villages that are situated further from the health post, they just made sure that they had supplementary services to reach these communities who might not, in fact, come to the health facilities. So this is one of the ways that you can redesign the services to accommodate cultural practices rather than dismantling them. It's also important to place the hepatitis B dose vaccine. In Sao Tome, we saw that if you have the vaccine available in the delivery ward, all it means is once the mother has delivered, you can provide easy access, direct access to the vaccine, rather than asking the mother after she's given birth to go all the way to the immunization center, which might not be where she in fact gave birth. Also, the design of the vaccine. So the vaccine is offered in a multi-dose vial, a 10-dose vial, which just means that from one vial, you can vaccinate 10 babies. And it's been recommended that you can store the vaccine for up to 4 weeks after you've opened it. So once you have the baby, just give it, store it safely, and when the next baby comes in. But sometimes what nurses are doing is that they are waiting until they have 10 deliveries. And when you do that, then you're delaying the vaccination for some of these children. So it's just trying to stress the training and the guidelines for these healthcare workers. So I'd now like to touch on selective hepatitis B birth dose vaccination. So there's the universal approach where you vaccinate every baby in sight. And there's the targeted approach where you in fact have to screen the pregnant woman, confirm that she actually has a hepatitis B virus infection, and then give the vaccine to her child once she delivers. So the trouble with selective or targeted hepatitis B birth dose vaccination services is that it has been shown to be a principal barrier to achieving high vaccine coverage. Reason being that you actually have to have a really good screening program in place. And based on our experience so far, I can assure you that we don't always reach every pregnant woman with screening. The other trouble with screening is you need a rapid test, a way that you can find out whether or not they're infected as soon as possible. And it's unlike HIV. You actually have to draw blood, send it to the lab, have it tested, get back to the woman some days or weeks later, and let her know what her results are, and then make plans to vaccinate the child. But during that time, you could in fact lose contact with the pregnant woman. And that's where the gaps are. And so with the universal approach, you're vaccinating everybody. There's nothing wrong with vaccinating a child whose mother does not have hepatitis B, just means that they're going to have no protection. But sometimes that approach has gone for the selective approach, possibly because of finances. But it tends to cost more. The testing tends to cost more than just giving the vaccine, as I've said. So there are several opportunities to miss the mother and the child, especially if they're not coming into their ANC services or they're not delivering at the health facility. So now that I've told you what the problem is with the selective approach, it's a good time to let you know that South Africa announced early this year that they will be rolling out a selective hepatitis B birth dose vaccination program. And the national guidelines recommend that all pregnant women should now be screened for hepatitis B. And according to them, the Department of Health, there are discussions underway to see if we can include other groups. And by other groups, they mean if we can broaden it and make it more universal. But for now, they're going with a targeted approach. The rationale is that we might have limited evidence as to whether we have a huge mother-to-child transmission situation in our country. But it's because we just don't have enough studies that have looked at what the risks are and in which populations. We know that those living with HIV tend to be at high risk for transmitting hepatitis B vertically. So given the gaps in evidence, we conducted a retrospective study looking at the prevalence, the seroprevalence of hepatitis B. And we looked at this in 3 specific groups. HIV-exposed infected children, HIV-unexposed uninfected children, and HIV-exposed uninfected children. I hope I've said that right. So children living with HIV, HIV-exposed uninfected, and HIV-unexposed uninfected children. And our interest in these populations is because there has been an under-prioritization of viral hepatitis among those who have been exposed to maternal HIV and those who have not, compared to those who have not. And so we wanted to better understand this because without the necessary information, it compromises rational vaccine decision-making, leading to decisions like going for a targeted approach, perhaps. So in this particular study, we had serum samples from 513 children, ranging from less than a year, from 4 weeks old to as old as 12 years. And we also had maternal data, and so, or their records, clinical records. So among the 513 women in this particular study, we found that 19.7% of them had been diagnosed with HIV, which is comparable to the current burden of HIV among pregnant women in our setting in the Western Cape. So this is in the Western Cape. And the median age among the women was 29 years. We did have some teen mothers, but this was mainly in the HIV group. In terms of level of education, 92% or almost 93% of the women had a secondary education or higher. And in terms of their socioeconomic status, most fell in the upper middle category. So we had 412 children who had not been exposed to HIV. Their mothers were HIV negative. And then among the 100 whose mothers were HIV positive, 74 were unexposed. They tested negative, sorry, uninfected, they tested negative, and then 19 were living with an HIV infection. So we tested for serological markers of hepatitis B infection and immunity in the serum samples from the children, just the children. And we looked at also their vaccination records as well as the maternal clinical history. And I'll share just some quick analysis from this particular study. So we found that among the children, those who had their vaccination records, 83.5% had received all 3 of their infant doses. Remember, we don't have a birth dose, or we didn't have a birth dose at the time. So 83% had received their hepatitis B vaccination, and coverage ranged from 80% among those living with HIV to 97.5% among those who had never been exposed or were not infected. What I'd like you to pay attention to is really the difference between the vaccination coverage and the antibody response. So in most of the groups, it was comparable between those who had received all 3 doses and their antibody response. But in the HIV group, the children living with HIV, the antibody response was as low as 40%. Now, this might mean several things. It might be waning of immunity, quicker waning among those living with HIV. It might also, it doesn't necessarily mean that they are not protected, because we know that with hepatitis B vaccination, there's an amnestic response. So you could, if you did give another booster or they were exposed, they will mount another immune response, but we'll come to that. But what we did see is that the rate of exposure based on detection of anti-HBC among those living with HIV was 11.1%, which was higher compared to all the other groups. So the risk of infection was in fact higher among those living with HIV. And the markers of infection were almost entirely detected among those under the age of 1, meaning that they most likely got the infection from mother to child rather than during the course of childhood, which I think is important in terms of our decision making when it comes to the hepatitis B vectors vaccine. So as I wrap up, I think what I want to stress is the complex interactions between hepatitis B vectors vaccination and the health system. It's not as simple as just introducing the vaccine. It's important that we expand access, but at the same time, we need to strengthen some of these challenges that I've raised. And so strategies aimed at strengthening program performance will have to be multifaceted and context specific. Our findings also underscore 5 major considerations. The first being that there's a need for enhanced government buy-in and intersectoral collaboration to actually introduce the vaccine and which approach to go for. And we also need to establish and implement clear policies and guidelines, because we're seeing what's happening when the policies and the guidelines are not clear and what the delivery agents might be choosing to do. The design of the program or the health service needs to be responsive and needs to adapt to the context. And programs should also acknowledge contextual underpinnings. So when it comes to cultural practices or religious practices that influence the choice of where to give birth or how long you stay at home. So it's also important to leverage various cadres of healthcare workers in some communities, particularly traditional birth attendants or doulas. And lastly, I'd like to leave you with this in terms of what the implications of the study are. It's important to stress that our viral hepatitis elimination strategies in endemic settings like South Africa are incomplete without expanding access to integrated PMTCT services to provide timely diagnosis and linkage to care, as well as linkage to effective prophylaxis, including universal hepatitis B birth dose vaccination. And so with that, I'll stop here. Thank you so much.
Thank you so much, Edina, for that wonderful presentation. Questions from online and also in-person attendance? Attendees, rather.
Yeah. So for the children that had HIV Edina, you said the anti-HBC was higher in the HIV-infected infants compared to all the other groups. I'm just curious as to whether the mothers were actually on ART during the pregnancy, because that's a bit interesting, because I did a similar study for my master's, and what I found was that there were higher rates, so we ended up having 114 infants that had HPV. And then when we looked at the mother-infant pair system, sorry, I forgot some of the details because it's 5 years ago. But basically, the infants that ended up having HPV were born to, I think we had 4, sorry. They were born to mothers that were HIV negative. So we did not get any from the mothers that were actually HIV positive. And well, we ended up assuming that this was probably because the ART that the mothers were on had protected, reduce the viral load and therefore reduce the risk of passing the messaging to the infants, because we know that one of the factors for vertical transmission of HPV is very high. So the mothers are minority. Then you expect the vertical transmission to be low. But this is kind of the complete opposite of that theory, and also what I found in my study. So I'm just curious as to why.
No, so you raise a very important point about whether or not the mothers were on ART, and even the children themselves, were on. So when we look at the clinical records, and you remember this is like a retrospective study, so we're basing this on the data that was presented at the time that the parents and the children were enrolled. And so when we actually looked at the data, most of the mothers were in fact on ART. Whether they were adhering is a completely different situation. And the same for the children as well. We had records of which kids were or were not. And with ART, of course, we know that it includes a hepatitis B active component. And so it's an important tool in terms of preventing mother-to-child transmission of hepatitis B. So we did have records of them being, most were in fact on treatment, or reported that they were. But whether they were adhering is a completely different situation. We will also be looking at the viral DNA.
That's fine.
So that will probably tell us a little bit more. And we're still testing for that.
Okay. That was my follow-up question.
Thanks, Lisa.
Thanks so much for the great talk. I was just wondering if you could talk me through the screening process for mothers for hepatitis B. I do a bit of work with syphilis, and I know that's also complicated because, you can do a rapid test, but it doesn't tell you anything about how active the infection is. So I'm just wondering what the overlaps are with hepatitis B screening, and then also what the screening guidelines are currently for pregnant women.
Yeah, so also a very important point, because what we're trying to go for is an integrated approach where we're preventing vertical transmission of HIV, hepatitis B, and syphilis. So with hepatitis B, we do not have a commercial rapid test, which I think, puts a spanner in the works. It means that you need to draw blood, take it to the lab, and then you test. So the recommendation is saying if the mother tests for the surface antigen, which is a telltale sign of chronic infection, then you need to, flag her for, to vaccinate her child once she's born. That's what the recommendation says. But in terms of whether or not she'll be put on treatment, I think the guidelines have also changed given the recent report. Before, we would say if she also tests for E antigen, which shows that she has an active high infection, or, if you do a PCR and DNA test and you see that the viral loads are high, over, I think, 20,000 copies per ml, then you need to put her on treatment. So not everybody has to be on treatment. But now I think the guidelines are saying if you have surface antigen, then you need to implement some form of prophylaxis to prevent transmission.
And are all women screened during pregnancy? What are the guidelines on screening in South Africa?
Well, South Africa now, the guideline is that all women should be screened. Before, it wasn't, we were going for the test and treat strategy where we're trying to encourage more women. You test for HIV, do test for surface antigen, for hepatitis B as well, but it wasn't as strong. But with the targeted approach now being rolled out, the recommendation is that all pregnant women should be screened for surface antigen.
Well, my question also is regarding the new guidelines in South Africa. So now, after the screening for those who will test positive, will they vaccinate the babies in the facilities, or they will send them to the babies clinic? I mean, for the birth dose.
Yeah, I wish I could tell you, because that is, I think, all of our frustration with this approach, because you might get a woman come in during her ANC and you test her and she comes back for her next visit, and then she gives birth and then you vaccinate her child. Or you might get a woman who gets screened in Cape Town and goes to give birth in Eastern Cape. And the question is, will her records follow her so that her child will be vaccinated? But in terms of where they will get the vaccine, I think that we know the best approach is to have the vaccine available in the labor or delivery ward, so where the woman is actually given birth, and that is the best.
The struggles with the levels, if the woman deliver at secondary or tertiary hospital, we know that they move to an MAU and primary, and then it's a bit complicated there.
Yeah.
And also, do you have an idea of when in the ANC program they will actually get tested for HPV?
I think that your first contact, with the woman is when you want to test. Unfortunately, for some, it might mean that when she comes in to deliver, because some might not attend their ANC visits.
That's. I mean, if you're going to test her 3 months, if she's negative, she might get infected in between. You know what I mean?
True, depending on what
If you're basic
in that time.
Yeah.
Yeah.
That on.
Edina universal birth.
You're going to base the birth dose on that, and what happens to those that get infected during the pregnancy, after they've been tested.
Yeah. So I mean, there are a lot of complications in terms of timing, and that's why the selective or targeted approach is so complex. But as I said, the decision making is also complex. Each country has to adapt to the guidelines and decide what works best for them. The one positive is by having a universal screening program running, we will be able to better understand what our risks are and better inform decision making. Unfortunately, I feel like, who goes missing during this time as we collect data.
But I mean, the targeted approach, they could use the rapid HPV test by the bedside during delivery, just before delivery. That could work better.
We don't have a commercial.
Oh, we don't.
Edina, are you aware of an economic evaluation has been done to compare between the cost effectiveness between? Yeah. I mean, are you aware in South Africa has been before opting for this option? an economic evaluation to do like to compare the cost effectiveness of testing screening versus universal birth dose, because that would give like I mean
That's an important point, and in fact, I should go and check on that. What I do know from other countries, and I'm sure our decision makers considered that, is when it's been compared, the best approach seems to go for a universal dose. But of course, even with the universal dose, there are all those systemic issues that can come into play and determine whether you have an effective program or not.
or both.
Or both. So
Yeah.
so that's, yeah. I don't know if there are any questions online.
And the questions online, Tim, I don't see a hand up. You can unmute and ask your question or make a comment. As you wait for them to think, Edina, the 24 hours cut-off time,
Yeah. Well, recommended.
recommended one.
Yeah.
There been any evidence on, at what stage after birth do you really lose the effectiveness of the vaccine?
Yeah.
Is it after 3 days, after 4 days, 7 days? Is it known?
So it is known that even up until 7 days, you still will be able to give maximum protection. But after that, it starts to reduce, the opportunities start to reduce. And then the reason why we have a 2-week cutoff is to also allow 4 weeks before your infant vaccination actually starts. So the recommendation is best time day 0. But 7 days is still beneficial, highly beneficial. And 2 weeks, you still have a good opportunity. But after that, you're of course moving into your infant vaccination.
So let's say 24 hours is as good as 14 days, okay? Or 7 days.
Yes.
Do you think from practical implementation, it would make a difference if the policy is saying it's written, give the vaccine within 7 days?
In which way that?
In terms of the healthcare, the vaccinators themselves being able to stick to that, because you said in some cases they see that they've missed the 24 hours, then they don't.
Then they don't, yeah.
So are we setting a very strict timeline that it's possible to cause missed opportunities to vaccinate because of that?
Yeah.
So if we were to change from 24 hours to 7 days, for example.
Yeah,
Based on the systemic issues, you think that would make a difference?
So you're right. So the any opportunity is a good opportunity, and some protection or more protection. The main thing is to provide protection. So I think it's how we go about wording it. Our healthcare workers need to understand why we have 24 days as optimal and 7 days as your next best opportunity and 2 weeks as most likely your cut off. But I think there's a lack of understanding with that. Some might think it's just a suggestion, but they know they have other birth doses to offer. So they think, let me just batch all of them anytime before they leave. But operationally, that is your best contact. When the baby and the mother are in front of you is your best chance to actually deliver the vaccine. But if you have to tell them to, go and then come back 7 days later or 2 weeks later, you might never see them again. So there are the operational concerns, as well as the fact that immunologically, you can in fact give the vaccine at 7 days and still offer the best level of protection. So I think it's just about clarity, but we shouldn't set a hard cut off to say 24 hours and make the healthcare workers think that if they shouldn't offer it after. So I think there just needs to be that understanding that as soon as you have the mother and the baby in front of you, that is your opportunity to deliver the vaccine.
Okay. Any comment?
So in my thinking, is sort of the primary motivation for the birth dose the vertical transmission, or are there also immunological advantages for the child having a birth dose in addition to the infant schedule?
Yes,
as well.
So it's been shown that if the child receives the birth dose at birth, followed by 2 or 3 doses during infancy at 6, 10, and 14 weeks, they are protected up at like they have 98 to 100% protection. And of course, this is also lifelong. So there's also that immunological benefit. And I think we see that with the children living with HIV. You know, perhaps if they receive a birth dose followed by these 3 doses, we might have more of an immune response. But in the South African setting, we actually have 4 opportunities to provide the hepatitis B birth dose. So there's the 3, but there's also a 4th opportunity, and so there's more chances. But I think the recommendation is saying that if you offer the birth dose with 2 or 3 additional doses, you're going to increase the likelihood of protection anywhere from 98 to 100% lifelong.
And another question online. Edina, lastly from me, the high infection rate that
Yes.
is reported in Africa.
Yes.
Do you think is it sort of a homogeneous infection, or is concentrated in certain pockets, population of certain characteristics? So, for example, the underserved communities, because the issue of equity that you talked about is important. And I'm asking that in the context of targeted vaccination. We talked about targeted vaccination in the context of screen and vaccinate, or universal vaccinate everybody. But could we look at targeted approach where you target communities where the infection rates
are in fact high, and population groups that have a high
Yes.
risk?
Yes.
You definitely could do that, if you know these
Where?
populations and where they are and how you can reach them. So that could also be an approach. And I think that's what the South African Department of Health is saying, is that they will go for a targeted approach based on screening for now, but there may be further opportunities to say, okay, maybe for women living with HIV, it's a universal program for them, or other high-risk groups, we don't have to wait until we test them, and we are in fact going to just offer the benefits. So I guess it's also an approach. The challenge is just always operationally how you go about that and what the logistical challenges like.
Because we're currently getting mothers who got the hepatitis B vaccine,
Yes.
because the program started, I think, in the 80s.
Yeah, for South Africa, it was in 94.
The 90s.
Mm.
So it's possible that, some of the mothers who missed that childhood vaccination, it's because of, being underserved communities and being in certain socioeconomic settings.
Yeah.
And if that can be sort of confirmed, then one could also use that approach of targeting certain population, because that's when the infection rate is high.
Absolutely.
Because if you look at the childhood hepatitis B coverage that is shown, other regions is 80%, Africa is 72%.
Yeah.
But when you look at the infection rates, it sort of doesn't mirror that small difference in coverage in Africa and other regions.
Yeah.
So it shows possibly the infection has more to do with some special population pocket. And if we can't be able to pick up them, then it's possible maybe our targeted effort could focus in such populations.
Absolutely. A really good point.
All right. I think no other questions, no other comments. Edina, thank you so much. And enjoy the rest of the afternoon. Thank you so much.
Thank you. Thank you all so much.
Thank you. Bye-bye.
Thank you. Bye.